Recently, India has once again reported cases of Nipah virus in West Bengal, raising significant concern among the public. This is the second time that a Nipah virus outbreak has been reported in West Bengal. Every time this name appears in the news, one question immediately comes to mind. How dangerous is the Nipah virus? And can it cause a pandemic like COVID 19? In this video, we will clearly understand what the Nipah virus is, where it originated from, how it spreads, and what symptoms it causes. Most importantly, we will discuss whether Nipah has the potential to turn into a global pandemic and why even localized outbreaks create widespread public anxiety and place a heavy burden on healthcare systems. Let us begin by tracing the origins of the Nipah virus. The virus was first identified in 1998 during a severe outbreak among pig farm in Malaysia, particularly in a village called Sungai Nipah, from which it later derived its name. During this outbreak, the infection initially became evident in pigs. Pig farmers were the first to notice that their animals were behaving abnormally. At first glance, the illness appeared to be a routine respiratory infection, as pigs developed fever, labored breathing, and a loud, harsh cough, which was so characteristic that farmers described it as a barking or dog-like cough. Because of this distinctive feature, the disease was locally referred to as barking pig syndrome. As time progressed, the illness did not remain limited to the lungs. Gradually, many pigs began to show neurological signs such as muscle tremors, twitching, weakness, and difficulty in standing, and in severe cases, pigs collapsed or died suddenly. Notably, the infection spread rapidly within pig farms, especially in large commercial settings, as pigs were kept in close proximity with each other. Consequently, pigs became highly efficient amplifier hosts, producing large amounts of virus and thereby facilitating transmission to humans, particularly farmers and veterinarians who handled these animals on a daily basis. Meanwhile, pig farmers themselves began falling ill, initially presenting with fever and respiratory symptoms, and later developing altered sensorium suggestive of encephalitis. During the early phase of the Malaysian outbreak, health authorities believed that these encephalitic cases in humans were due to Japanese encephalitis. As a result, mass Japanese encephalitis vaccination campaigns were carried out, particularly in the affected regions. However, when new human cases continued to appear despite adequate vaccination coverage, it became increasingly evident that Japanese encephalitis could not fully explain the outbreak. Subsequently, detailed epidemiological and virological investigations revealed a previously unknown virus, later named the Nipah virus. Further virological studies clarified that pigs were not the original source of infection, but rather accidental victims of spillover from fruit bats, and their respiratory secretions played a crucial role in transmitting the virus to humans. Studies revealed that fruit bats of the Pteropus genus served as the natural reservoir of the virus, while pigs acted as amplifier hosts, thereby allowing efficient transmission to humans. From 2001 onward, similar repeated outbreaks of Nipah virus were reported in Bangladesh. However, unlike the Malaysian outbreak, pigs played no role in transmission here. Instead, humans became infected mainly through the consumption of raw date palm sap that had been contaminated with secretions from fruit bats. Raw date palm sap is a fresh, sweet liquid that is naturally collected from date palm trees. Farmers typically make a small cut in the trunk of the tree and place a container underneath, allowing the sap to drip out slowly, usually overnight. This sap is commonly consumed in its raw, unboiled form, especially in parts of South Asia, as it is considered fresh and nutritious. However, when the sap is left uncovered, fruit bats are often attracted to it and may contaminate it with saliva, urine, or feces while feeding, thereby making it a potential source of infection. More importantly, during these outbreaks in Bangladesh, a higher degree of human to human transmission was observed, particularly among close family members and healthcare workers who cared for infected patients. These outbreaks were also associated with a higher fatality rate and more prominent respiratory involvement. Around the same time, India also began reporting outbreaks of Nipah virus. The first notable outbreak occurred in Siliguri and later in West Bengal and Kerala, where hospital-based transmission was clearly documented. This highlighted the significant risk of person-to-person spread in healthcare settings, particularly when infection control measures are inadequate. More recently, 2 confirmed cases of Nipah virus were reported from a hospital in West Bengal. Importantly, extensive contact tracing was undertaken, and nearly 200 traced contacts tested negative. Due to its high mortality, lack of specific treatment, and capacity for human-to-human spread, explains why even small, localized outbreaks can cause considerable public anxiety and place a heavy burden on health systems. Now that we understand the background, let us discuss how the Nipah virus spreads. We know that the natural reservoir of the Nipah virus is the fruit bat, which means these bats carry the virus without appearing ill. They shed the virus in their saliva, urine, and feces. As a result, humans may become infected by consuming fruits or raw date palm sap that has been contaminated with bat secretions. Next, as observed during the Malaysian outbreak, pigs played a crucial intermediate role. Pigs became infected after exposure to bat-contaminated fruits, and subsequently, humans who had close contact with infected pigs, such as farmers, slaughterhouse workers, and veterinarians, became infected. In these cases, transmission occurred mainly through exposure to respiratory secretions or direct handling of infected animals. In addition to animal-to-human transmission, Nipah virus can also spread from human to human. This usually occurs through close contact with the bodily fluids of an infected person. Such fluids include saliva, particularly through kissing or sharing eating utensils, as well as blood, vomitus, urine, and feces. Because of this mode of transmission, family members and healthcare workers are at a higher risk of infection if proper precautions are not followed. Finally, it is important to emphasize that Nipah virus is not an airborne virus. It is not known to spread through the air like influenza or the common cold, and it does not spread over long distances through air. Therefore, casual exposure, such as simply being in the same room or breathing the same air, is not sufficient to transmit the Nipah virus. Thus, close physical contact and exposure to infected fluids are necessary for transmission. Now let us move on to the signs and symptoms of Nipah virus infection. One of the most striking features of Nipah virus is its high mortality rate, which usually ranges from 40% to 75%, indicating that a significant proportion of infected patients may not survive. The incubation period is time from exposure to the onset of symptoms, typically ranges from 4 to 14 days, although in some cases it can be as long as 45 days. Once symptoms begin, the illness usually starts in a non-specific flu-like manner, which often makes early diagnosis difficult. Initially, patients develop fever, headache, body aches, fatigue, and sore throat, and may also complain of nausea and vomiting. At this stage, the disease can easily be mistaken for a common viral infection. However, as the disease progresses, the virus begins to affect the brain and lungs. Gradually, neurological symptoms appear, including feeling unusually sleepy, tired, or unsteady, along with confusion, disorientation, and altered mental status. These features are key indicators of brain involvement. In severe cases, the condition may progress to seizures and rapid deterioration, with patients slipping into coma within 24 to 48 hours. At the same time or shortly thereafter, some patients also develop respiratory symptoms such as cough, shortness of breath, and difficulty breathing. This respiratory involvement not only worsens the clinical condition but also increases the risk of transmission to close contacts. In the most severe cases, infection can lead to critical complications, including profound inflammation of the brain, resulting in permanent neurological damage or death. Some patients may develop severe respiratory problems, including acute respiratory distress, while in certain instances, an overwhelming systemic response to infection can lead to dangerously low blood pressure and multi-organ failure. Thus, Nipah virus infection typically follows a progression from mild flu-like symptoms to severe encephalitis and respiratory failure, which explains the high fatality rate associated with this disease. Now let us discuss the investigations used to diagnose Nipah virus infection. The most important test for confirmation is RT-PCR, which detects viral RNA. This test can be performed on throat or nasal swabs, blood, cerebrospinal fluid, urine, or respiratory secretions, depending on the clinical presentation. In addition, once the virus enters the body, the immune system produces antibodies, namely IgM and IgG, which can be detected using serological tests such as ELISA. These antibody-based tests are particularly useful in the later stages of illness, as antibodies take time to appear. Since Nipah virus commonly causes encephalitis, CSF examination may also be performed and typically shows features of viral encephalitis such as mildly raised protein levels with normal or slightly increased lymphocytes. Furthermore, MRI of the brain may reveal multiple small lesions suggestive of viral encephalitis. If respiratory symptoms are present, chest X-ray or CT scan may demonstrate evidence of pneumonia or acute respiratory distress. Thus, the diagnosis of Nipah virus relies on a combination of strong clinical suspicion, relevant exposure history, and laboratory confirmation with RT-PCR as the cornerstone, supported by serology and imaging. Now let us turn to the treatment of Nipah virus infection. The most important point to understand is that there is currently no specific antiviral therapy proven to be effective. Therefore, management is primarily supportive and symptomatic. As soon as infection is suspected, the patient must be immediately isolated to prevent further spread. In the early stages, treatment focuses on controlling fever, pain, and dehydration using appropriate medications and intravenous fluids. As the disease progresses, many patients develop encephalitis, and management then shifts toward protecting the brain. This includes ensuring airway safety, controlling seizures with anti-epileptic drugs, reducing brain swelling, and closely monitoring the level of consciousness. If respiratory symptoms worsen, patients may require oxygen therapy or even mechanical ventilation in the ICU. Although some antiviral agents such as ribavirin and experimental monoclonal antibodies have been used in limited settings, their benefit has not been conclusively proven and they are not considered standard therapy. Hence, treatment of Nipah virus infection remains largely supportive rather than curative. Now an important question. Can Nipah virus cause a pandemic? In simple terms, a Nipah pandemic is possible in theory but highly unlikely in practice, at least now. The primary reason is that Nipah virus is not transmitted through airborne or long-distance droplets like influenza or COVID-19. Instead, transmission requires close physical contact with an infected person or direct exposure to their body fluids. Therefore, casual contact and routine social interactions do not easily spread the infection. In addition, the clinical course of Nipah virus further limits its spread. The illness is usually severe and progresses rapidly, causing patients to become very sick, bed-bound, or hospitalized early in the course of disease. This significantly reduces their ability to move freely in the community and transmit the virus to large numbers of people. For these reasons, Nipah virus does not behave like typical pandemic viruses. However, it is important to emphasize that because Nipah virus has a very high mortality rate, lacks a specific treatment or vaccine, and can show human to human transmission in closed settings, it still poses a serious public health threat and must be monitored closely and managed with strict control measures.